who don't know who we are, we're CAPA trainee committee with a bunch of trainees and young faculty that have the mission of encouraging collaborative research and education in pancreatology. This teleconference started about a year ago, where monthly we would host a renowned pancreatologist or any basic scientist with an interest in the pancreas. And the goal of this teleconference is to really inspire younger trainees to take an interest in pancreatology, and also ask any questions related to career, research, education, and just gives the trainees a chance to sort of interact with the pancreatologists and people who are renowned in the field to share some of their wisdom and experience. So with that, we're really fortunate to have Dr. Cote with us, professor of medicine at Medical University of South Carolina. He really needs no introduction, but lead investigator in some of the really big impact papers, including a paper in JAMA that looked at biliary strictures from chronic pancreatitis, comparing plastic versus metal stents, and a principal investigator in some of the other bigger grants. So today, our topic is conducting high-impact research, things that you wish you knew as a trainee. And I sent you a copy of the list of questions that we wanted to talk about today, Dr. Cote. So with that, I just wanted to sort of start and go over some of the questions that the trainees sort of wanted to discuss today. And to start us with the first one, what are challenges of being a busy advanced endoscopist and being a clinician scientist? What are your tips for time management to be successful in both?
Yeah, I wish I had the right answer on that one. I'm still trying to figure it out, Peter, but obviously when you have the technical capabilities of being able to do particularly ERCP, but even endoscopic ultrasound and other luminal endoscopy, what that does is it exposes you to call obligations, and obviously just patient care. Patients come in with cholangitis and so on, and very few people can sort of turn that these patient care obligations down. And so as compared to a true medical pancreatologist, where you're not going to be pulled into those common clinical scenarios, you have to be prepared to fulfill that clinical obligation. So it's very challenging. So I think the best way to address that is to have mentors and division chiefs who recognize your potential as a clinician investigator, and basically assures you of the protected time that you need in your early career to be writing papers and writing grants, but also having enough time to perform these procedures, because if you don't do enough of them, you're not going to be any good at it. Mm-hmm. So, that was important for me as I was coming out of my fourth year, was getting into a position where I had senior partners that, clearly had content expertise in the diseases I would be studying and treating, and they could back me up with technical issues that I could come in, arise from, but then also just having enough bodies there that I wouldn't be committed to doing, endoscopy 4 or 5 days a week. So, finding an institution that is willing to invest in you, because very few people are going to come out of their fellowship with adequate funding to protect themselves. So it requires a division chief and a department to have the vision to say, well, we're going to invest in this person and give them adequate protected time, which in my opinion, if you really want to be a legitimate clinician researcher, you need at least 2 full days. Half days don't exist. Half days become quarter days, and then you end up just, by the time you sort of wind down your clinical stuff, you have no energy to commit to the research. So you need full days, which are harder and harder to find as you get older. But in your early years, it's really important. And I'd say a minimum of 2. And that means, so on the part of the division chief, they need to invest in it, meaning they need to not put you on call schedules and custody schedules. but then also you need to be committed to it, and you don't, violate your protected time by adding cases on, getting them done, and kind of getting into that spirit of being a go-getter in the endoscopy suite. Try to balance those forces. And of course, it will mean, you have to be aware of the fact that it will mean probably a reduction in your salary compared to someone who's full clinical. Your department should pay you adequately so that it's a competitive salary. But obviously, if you're not doing as much clinical work, you're not going to make as much as a full-time clinician. But that's one of the trade-offs of being committed to research anyway.
Well, that's very helpful. Anyone in relation to the time management, does anyone have any questions you guys want to ask Dr. Cote?
I can't emphasize enough the idea of these half days of clinic or half days of endoscopy they are not good for being a productive clinician investigator, especially with interventional work, because the patients are more complicated, the cases are longer, they're in the recovery room longer. It's just not realistic.
Dr. Cote, I was actually hoping to ask a question regarding that.
Yeah.
So I'm Sam. I'm actually a third-year fellow at Colorado. I'm going to be the advanced fellow there next year.
Oh, nice.
So one of the tricky things I feel like as an advanced endoscopist is that, I feel like you probably should do minimum 2 days of scoping at least a week as an attending, just to keep your skills up. And then if you want to have any clinic responsibilities as well, I guess that would leave you just 1 day a week for that if you wanted to have like 2 protected days a week. So I was wondering how you would navigate that and what kind of balance you would try to find in that.
That's exactly how my schedule started when I came out of my 4th year. Is I had 2 days of interventional endoscopy blocks, and so that means a lot of places don't have the volume to support someone who can just do interventional work. So you might get pulled into some general GI, which I think is okay as long as you're getting the volume, the interventional volume that you need. But so 2 full days in an endo suite, I think at a busy place where your days will be packed and you'll be busy, will give you the volume that you need. And then, and then the clinic, I think a half day or a full day in clinic is fine. And I think if you are particularly in the pancreas, to not have a clinic you're not going to be a legitimate pancreatic, disease expert if you don't see these patients in clinic, because they go way beyond the stuff we can offer in procedures. So you do need that clinic time.
Okay, thank you.
In terms of like time management, any practical principles that you abide by? I've heard many principles. Like one person that I talked to, a senior guy, he's like, until I clear my inbox that day, I don't go home. I don't try to take work to home so that I can focus on writing, grants and stuff like that. What are some of the principles that you go by when it comes to managing time?
So, that's going to change depending on where you are in your life, like as far as personal life. I mean, obviously, you need to have a good work-life balance. And if you become too obsessed on the work side, I think it will detract from your overall happiness. And then as a result of that, your professional performance will deteriorate, maybe later. So when I was in my fellowship and in my 4th year and even in my 1st year out of fellowship, I didn't have any kids. And so to me, my time management was a little bit easier back then. I could work in the evenings. I didn't have to go home and chase after the kids and get them to sleep and stuff like that. On a Saturday morning, I could get up and do 2 or 3 hours of, those are the best times, is when you have totally uninterrupted time, like on a Saturday or a Sunday morning, and then you can still have the rest of your day to do, non-work related stuff. So, but I think those were important times for me, was to be writing. You're a lot less efficient when you're younger because you don't have as much to build off of.
Right.
As far as papers, a lot of the things you're doing are de novo. So you need more time to write. And those were important times for me back then. But now it's totally different. Like I do very little work on the weekends at all. And so I think whoever was telling that to you, clinical stuff, I always make sure everything is wrapped up before I go home that night. That's important to the extent that's possible. Obviously, there's things like following up on biopsies and so on and so forth. So you may have to do that later, but every procedure note needs to be written. Every letter to the referring physician needs to be signed and sent off for, to your administrator to process. Don't leave those things hanging, except for the really exceptionally busy days. And then I still try to, like, at least those are the nights where I will get home, and after the kids are asleep, I'll go back on my laptop and finish those things up. So, but that means on those days, I'm doing very little academic work. It's all reactive stuff, responding to emails or urgent issues about a grant or a paper that, is coming back. And then on those protected days, what I'll try to do is, personally, I work best, in the mornings. And so what I try to do is for the first sort of block of the day is when I try to tackle the most difficult, things. So if it's writing a grant or writing a paper that's not drafted. And then later in the day is when I'll do, when I'm sort of a little bit more fried, basically, I'll do things that are more formulaic, like, peer reviews, maybe edit something that's already been written by someone else, work on a slide deck for a talk that I need to give, that type of thing. So that's how I balance my day. But for people that are night owls, they may want to shift it differently. But I think kind of dividing the day broadly into those kind of blocks is important. But trying to do it within the clinical setting is impossible, I think, except for things like inbox maintenance and so on. Those types of things I do try to do as much as I can on my endo days, so that way I don't walk into an academic day and I've got an inbox that's like completely untouched from the last 4 or 5 days. Does that make sense?
Yeah, that's very helpful. Okay, moving on. One of your major projects, I guess he means grants, both you and Dr. Yadav act as primary investigators. What are the pros and cons of writing grants with investigators from different centers?
Yeah, so I'm a big advocate of this. I mean, most of the things that I've done are in the role of bigger things are in the role of like a co-PI or a mentee mentor. And so I think as a co-PI, this is where, no one is great at everything. And so I recognize that I'm primarily an interventional endoscopist and clinical researcher. Diraj is a bona fide epidemiologist who really is committed to, pancreatic disease, obviously epidemiology, and he doesn't do the procedures. So I have, certain opinions and views of what's important to the field of medical pancreatology, and he has different, and they're very complementary. And so I think when we start to put our ideas together, there's a great amount of synergy there. So complementary. Now I think if let's say I paired up with someone who was another interventional endoscopist who just happened to be in another center, I don't think there's as much of an advantage there, because while they may have some institutional differences that might bring a unique perspective to the equation, the complementary sort of skill sets are not there. So the best things that I've written have always been with someone who brings a unique angle. So Diraj is medical pancreatology. Some of the translational things I've done have been with true pancreatic cancer biologists, and they clearly bring a different amount of expertise. So that's, I think those are the pros. The cons are that it requires, obviously a lot more coordination and careful organization. It's a lot easier now with like the cloud, so you're not like co-writing something and he's got one version and you've got another version of a document. Communicating very well, trying to, in advance outline and delegate sort of responsibilities about, I'll focus on this part, you focus on this part, and then we'll put the two areas together. So if you have a good co-investigator, co-PI, and they're on time and efficient, then it's all that. Those types of things are usually they fall right into place. If you have someone who's not as diligent with time management and they're like running behind on their components, then it can become frustrating. I've not personally had that experience, but I can see how that would be a major con. Some may find that, are you sort of giving up some of the limelight of the prestige of a project? I don't think that's an issue in any way. So I would discourage you from thinking along those lines. You definitely want to be clear on things like authorship, obviously, up front. More and more we're seeing co-first authors, and I think people recognize the value of that. I don't think it detracts from from being just a single first author. And of course, that's at my stage of my career, being last author is as important or more important now than being a first author. So for you guys, if you're trying to do something early in your career, you definitely want to be transparent up front about, you know, who's first, who's last, because you guys want to be first authors primarily at this point in your career.
Okay. All right. Well, that was very helpful. Moving on, you trained nearly entirely at Northwestern for med school, residency, and fellowship before pursuing your advanced endoscopy training at WashU. How did you feel receiving the majority of your training at one institution affected your career?
Yeah, that was a good question. You know, obviously, if you're happy in a place, it's very hard to leave. And there's the personal forces about, you know, if you have family and other, you know, reasons that you want to stay in one area. You know, I don't think an individual should feel obligated to move just for the sake of being in a different institution. There's a lot of advantages. You know, you start a fellowship, you know how the hospital works, you kind of hit the ground running. It's much easier as a first-year fellow to be starting to think about scholarly projects when, you know, you're transitioning within the same institution. So I think that was to my advantage for getting some of the, you know, papers that I wrote during my fellowship. I think I was able to hit the ground running a lot faster than I would have if I had gone to a different institution. But I think that overall, though, it's more of a negative than it is a positive, because I didn't realize like how big the world was basically until I got to WashU. It was a totally different way of training. It's a way of practicing in endoscopy in particular, and so the whole world kind of opened up for me. That year was, you know, such a unique year because it's so technically focused and you're so protected from all the other kind of nonsense of academic medicine and just being in a job. So it was a good opportunity to be in a different place and just focus on learning how to do the procedures and doing research, you know, around those procedures. So I think if you're given the choice, if all else is equal and you have the option of traveling to another institution for a component of your training, I would encourage that. But on the other side of it, I think there are some idiosyncratic advantages to staying in your home court. And so if you do that, take advantage of it basically, and really try to be proactive in the last part of your residency, starting to get your projects going that you would carry on through your fellowship.
That's very helpful. Any questions in relation to that? Anyone? Before we move on? Okay. All right, moving on. You've described an interest in studying interventional endoscopy training. Within pancreatology, one area of interest is a lack of training in pancreatic ERCP. How do you believe training programs should address this deficit when there's relatively low volume to begin with?
Yeah, that's a tough question. It's complicated because, you know, the science of pancreatic endotherapy is so poor, and that is reflected in the differences in practice, right? So who is offered pancreatic endotherapy in one institution varies to another, and that's because we frankly just don't know who stands to benefit. So this is an area that I'm trying to get off the ground as far as, you know, I think we need to do more sham-based work in pancreatic endotherapy, which is something that, you know, I would encourage you guys to run with. If you go up and talk to an endoscopy audience about, you know, the efficacy of stone extraction, pancreatic duct stone extraction or stricture therapy, and there's no thought of whether or not it's the right thing to do. It's all about, you know, what's the best technical way to sort of get the stone out, and what's my technical success rate, what's my stone clearance rate. And I think that's very misguided, because I think when you look at the outcomes that are published on pancreatic endotherapy, it's laughable. The ESG guidelines report that the clinical efficacy of endotherapy ranges from, you know, the high 20s to the low 70s as far as, you know, which is across the board. Basically, I mean, we don't know. I mean, it's right. I mean, so it's very much within what would be a sham effect, which could be as high as 40 or 50% in the surgical literature. And this is basically surgery, you know, so The disease, as you know, can fluctuate. Pain can subside on its own or with conservative management. And whenever we are engaging in endotherapy, it's usually in patients who have an accelerating disease process. So I'm kind of going off on a tangent, but pancreatic endotherapy is tricky because it's based on a weak foundation of evidence. It's an area that needs to be studied better. But as a result of that, from a training perspective, if you come and work with me, my pancreatic endotherapy practice is going to be very different than a lot of the other major institutions in the country. It's basically a Wild West. So I think if you want to be well trained in the technical aspects of it, because I mean, if you don't know how to clear a pancreatic duct stones or adequately treat a pancreatic duct stricture, then if you can't get technical success, you're never going to figure out who is going to stand to benefit. If you're technically unsuccessful. So the way to do that is when you're training, go to places that have a lot of volume in it, relatively speaking. And you're typically going to want to be training with people that have been doing this a little bit longer. So like I can tell you that in my first couple of years out of training, I was definitely much more of a scope grabber than I am later on, as far as just giving the fellows more latitude to do things. There's a understandable, lower threshold to take over a procedure. And with pancreatic endotherapy, it's one of these things where if you're not doing it well, you can really cause more harm. You can introduce infection and leaks and all that sort of stuff. And so, and they're just hard cases. I mean, they're just not easy. You get a stone there and you can't get the wires through. And so, being with experienced people that are aggressive with pancreatic endotherapy is probably what you want from a training perspective. But you also want to be with people that have an adequate equipoise on what the role of it is, because otherwise you might get brainwashed into thinking like, this is panacea, and every patient that walks in with a dilated pancreatic duct is going for an ERCP. So we have to figure out that middle ground. We have to do a better job of patient selection.
Yeah, I think you raise a really good point that the literature is so heterogeneous and the quality is so variable. We really don't have a substantial scientific evidence to guide us. So I guess there's a technical aspect to this, and there's the patient selection and knowing who will benefit from pancreatic endotherapy. And as you mentioned, I think even within an institution, like everybody's how to approach it. So it just definitely needs a lot of work, but it is encouraging to know that you're one of those people that are pursuing scientific rigor and in trying to answer these important questions. And I think it's important for the trainees to see that, because right now I think we're very much dependent on retrospective series and things like that. But to see someone conducting clinical trials, I think will encourage us to do the same and pursue the same. So
yeah, and I think it's with you all being young, you have the chance to ask the tougher questions. So again, like one technique versus another to achieve technical success, to me is relatively low interest. Now that's what gets, that's GIE is inundated with that type of literature, and there is some place for that, but the harder questions are, can we look at a patient up front and figure out, that this one is not a good candidate, this one is, why? The complex mechanisms of pain and chronic pancreatitis, and actually even non-pain, right? So there's some that would believe that maybe there's a role for endotherapy as a prophylactic intervention to prevent, later deterioration of pancreas function.
Right.
So those types of questions all need to be answered, and this is where, with the endoscopy skills, I think you do have an advantage because you know about some of the issues that come up in treatment. We work much more carefully with pancreatic surgeons, which is another aspect of this disease, with people getting treatment. So I think you know the phenotypes better when you're being sent these patients. And frankly, in the community, they just they see stone or they see dilated duct. It gets sent to people that do ERCP. It doesn't get sent to people that have an interest in pancreatology. And I think not as obviously as a general rule, but essentially your practice is going to be bigger, and it gives you that advantage, especially from a clinical research perspective.
For sure. Okay, moving on. As the chair of the ASGE Research Committee, do you see any opportunities / mechanisms through which trainees interested in pancreatology can initiate projects of interest to the ASGE?
We touched a lot on that, I think, in what we've just been talking about, but I think, again, there's a lot of interest in, studying pancreatic endotherapy in particular. The ASG is obviously going to be more of an endoscopy bent society. So I think that's the society that would probably be more inclined to some of the technical questions that are revolve around endotherapy. And frankly, a lot of the membership, the leading membership of the ASGE are not pancreatologists, they're interventionalists, and so they are not as attuned to some of the things we were just talking about. So with ASG, I think it's probably strategically better to focus on the technical challenges of endotherapy and training in endotherapy, pancreatic endotherapy. But if you can bring in a component of, the relevant clinical outcomes and saying, look, we don't know, is pain the best outcome measure? Is it some sort of a conglomerate that incorporates quality of life and performance status, pain-related disability, exocrine function, endocrine function, kind of all those things come in. So if you have a proposal that is focusing perhaps the primary intervention or the primary variable being studied is something endoscopic related, but you bring in this interest in systematically studying a lot of these other outcomes that interventional endoscopists don't typically think of, I think that would be a good angle from the ASGE. I think if you really want to, the other societies, I think, would also welcome the ACG probably even more so about training challenges. They seem to be more attuned to, what happens in the community environment around ERCP and pancreatic endotherapy. The AGA is, I think, I don't have as much experience with it on the research side, but it can be pretty competitive because you're competing against all these other disease entities. It's not as narrowed as the ASGE. But that's not to say there isn't an opportunity there. And then, of course, the APA and the NPF, I think, have some opportunities as well. And, of course, there, I think there's a lot of basic science competition, but really carefully done clinical research or translational research, I think there's an opportunity there with the pancreatic societies.
And I think one of the challenges for trainees, especially in a program where they don't have a strong pancreatologist's presence, if they're interested in pancreatology, it's sort of hard to get involved in research and get your feet wet. Do you have any pieces of advice for trainees who are in a situation like that, who want to get involved in research, pancreatic research, but perhaps don't have the mentor on site to guide them?
Walter, I know, is really trying to work hard on this through CAPER with this long distance mentoring program that this is the first year. It's a pilot. I think there's a small number of mentor-mentee kind of pairs that are being created. But I think here is where you try to. This is where being, I think, involved in CAPER and in the APA, you're going to be more likely to find content expertise around pancreatology. And then there's not a shortage, hopefully, at your institutions on interventional endoscopy. So you've got the two perspectives. So it starts with having interventional endoscopy mentorship that includes, again, an adequate amount of equipoise to be thinking about, this is not. There are some questions here that aren't answered. Some people are truly just believe there's no question that we should be doing this as we are, and they're more interested in about one technique versus another. So I think it's finding endoscopy mentorship where they have adequate a balanced view of the role of endoscopy in chronic pancreatitis, and then use the APA and CAPER to find the pancreatology expertise. But there are very few people, honestly, that are out there. So Diraj, that's why Diraj is so unique for me in that regard.
Great. All right. Moving on. You currently have UO1 looking at the role of sphincterotomy for acute recurrent pancreatitis in pancreas division, I believe. What led to your interest in this area, and how would you advise trainees to proceed if interested in obtaining grant support for their research?
Yeah, I mean, it stems from just the same things that you all should be doing in your day-to-day life, which is when you're doing something, whether it's in an endoscopy suite or if it's just in your practice, or you're with your faculty mentors, and they're making recommendations or doing things, and you say, well, what do we know about this? I mean, certain things are clear and a lot of other things are not. And especially when you talk about ERCP and pancreatic disease, you see patients that have terrible complications from ERCP. And so then you're like, boy, this is an intervention that had some reasonable chance of helping, but not even a clear cut. It wasn't a slam dunk that we were going to help this person. Now I've created this other sort of complication. And so that's basically how it's evolved for me. I mean, I think it's unrealistic to be in fellowship to be thinking about NIH funding, but I think as you're coming out of fellowship, you want to be thinking, if you really want to go down the road of high level research, you do want to be thinking about federal funding, NIH or VA or Department of Defense funding. And obviously career development awards are a great opportunity for that up front. And to be competitive in that, you want to be productive, you want to be writing papers, active member of societies like this, demonstrating a true commitment to academics. And then, for me, it was in my fourth year, I applied for a society grant, didn't get it. Then in my first year, my first or second year at IU, I applied for an ASG award, a career development award, which unfortunately doesn't exist now, and was able to get that. And that, along with just getting more papers written on a lot of retrospective stuff, but then some smaller prospective studies, it gave me enough of a CV to demonstrate that I was committed to this path. And the society grant was huge. That's actually what led to the JAMA paper. So I think that was serendipitous in a lot of ways, but I think more so than the JAMA paper, it gave me the grant writing experience and the credentials to go to the next step, which was a K award. And the K award, came with mostly time. It was more than it was like getting coordinator support and support for the actual execution of research. The K award was more about protecting my time. And so that actually got me from 2 days a week to closer to 3 days per week of protected time for 5 years, which is huge. I kind of got busier when I relocated to MUSC. But that was important because that helped me to be more productive, writing more papers.
Right.
The particular UO1 study stemmed from the project that we finished when I was at IU that we published on dual sphincterotomy versus biliary sphincterotomy for people with unexplained pancreatitis, thinking that SOD is a cause of pancreatitis in these people that have relapsing episodes. And it pretty clearly, albeit with the limitations of that study design, it pretty clearly showed that we were not helping people with pancreatic sphincterotomies in that population. Those were people with standard duct anatomy. But then, as you start to think about it more, and this is where Diraj, I think, was very helpful. I said, well, we need to do a proper sham trial of ERCP in this population. It gets complicated when you think about all comers with pancreatitis, because obviously with standard anatomy, you have more biliary pancreatitis, and how often is it that the gallbladder is the cause and there may be sphincterotomy interferes.
Right.
So division is very discrete. It's sort of a hot topic because of the recent discoveries around, its association with susceptibility mutations in CFTR and other genetics. So that raised even more specter of concern. But then on the other side of it is again, in the ASG world, if you tell the ASG, like, I don't think the bism, I don't think minor papillotomies work, or I'm not sure that they work, people are like, are you crazy? Like, we've been doing it for 40 years. And they say, well, show me the literature. And the literature is a 19-patient open-label sham trial, not sham, but an open-label trial. And it wasn't even for sphincterotomy. It was for stents. And then everything else is retrospective. And especially a disease like this, which has a sporadic kind of nature to it up front.
Right.
The same thing is, when you're an ERCP doc, you're referred patients who just had another episode of pancreatitis. They just found out that they had divisum. The disease is on the acceleration. And so we cut them, and then we follow them for a year, and most of them do okay. And so we say, well, hey, sphincterotomy helped them. Well, if you start to look at it with a more skeptical perspective, a lot of patients have a few episodes sort of stacked together, and then the disease just may quiet itself down for a period of time.
Right.
And so we really need a natural history comparison group, and that's where the argument for the SHARP trial, the U01 study, came from. But boy, I mean, that's taken me 4 years from the initial ideas and sort of starting to argue with the NIH about whether or not they should support it, and we've just started enrolling patients in the last couple of months. So that's like not something you want to try to tackle in your first couple of years, because if it doesn't work out, if you don't get funding, you've invested all that time and it hasn't panned out. So it's something you want to build up over the course of 10 plus years, which is how it evolved for me. So long-winded answer, but societies, and I think industry is another great place, especially if you have an interest in endoscopy. They have an interest in we have heavy device involvement. So while the research may not be quite as scientifically rigorous, it gets you traction. And I think industry can be your best marketers for your, for yourself, as you're trying to make yourself a name in the field. They will get you out there if you work with them, obviously in ways that are appropriate, and that you wouldn't commit to a research study that's heavily biased to favor something that they're doing. So you always want to control the ability to publish whatever the data may show, and be doing studies that are important to them, but at least have they're appropriately guided by the science as opposed to the profit desires of the company.
Very helpful. All right. Lastly, speaking of grants, you also had a K award with a focus on examining biliary strictures. What led you to, it's a lot of this I think you touched on already, but what led you to seek a career development award? And what advice can you give trainees who are thinking about applying for a career development award?
Yeah, the practical sides of a K award are that it's a low-hanging fruit for a young investigator. It's much easier to get a K award than it is an R01, especially in your first 5-10 years out. And then if you're successful, being a K awardee makes you much more competitive for independent funding later. So those are I think, key pros. It also gives you time. It's hard to have 5 years of 2 to 3 days off of clinical obligations if you're not funded. And the only way to get that kind of funding is through a VA career development or an NIH K award type of mechanism. Even the society career development awards will give you some time, but not the amount that a K award will provide or a VA equivalent. So to me, it's the ability. It gives you that early success with grant writing. It gives you time to refine the questions that you're asking. And it also allows you to acquire some extra skills. So like for me, it was, I had done a master's in research during my fellowship, which helped me to sort of be able to talk the language with biostatisticians and read the literature more carefully about, recognizing that when they say that the p-value was 0.03, but when you look at the confidence interval, and the confidence interval goes from 25% to 90%. And it's just because it's that indicates like a type 1 error. So you start to, those things are important to understand. But the K award gave me the time to really get into the trenches with biostatisticians and do some large data research when I was in Indiana and understand how to navigate large data better. So that was what the angle that I took, is it gave me that time to learn that skill set. For someone else, perhaps the K award, perhaps you want to study, let's say it's pancreatic endotherapy. Well, as part of your K award, you can say, well, I got a certain amount of training, but I want to learn, ESWAL, and I want to learn, some of these other newer techniques, the EOS rendezvous, and so on. And you could even sell that part of your career development is to maybe go to a place that does a lot of those types of interventions and get some of that extra training while you're on faculty somewhere. So that's just one example. Obviously, for those that don't have maybe as much methodologic research, it's time to get some methodologic research training, get a master's in research if you don't have it already. So there's a variety of angles, but to be successful with the K, you want to explain. It's more about explaining how it's going to make you a better investigator long term than it is about the science that you're actually proposing. So that's the key in writing a career development award. And then, of course, having a team behind you that has a track record of being successful in promoting others.
How many years do you have from the time you start as a faculty to be eligible for a K award?
I don't. You have to look this up to confirm, but I want to say it's 7 to 8 years from your terminal training, which I think your interventional year would count towards that if you do an interventional year. And you're also considered a young investigator for 7 to, it might be as much as 10 years out from your terminal training to be a young investigator. So that's for R1 and other mechanisms, independent mechanisms. It helps you with that. So I benefited on both. So the K award, obviously helps, but then my first R1 was within my first 10 years. And so I was put in a different bucket than, all the other, high level basic science people that are going for their fourth kind of R1 renewal type thing. So, the clock starts ticking. It goes by fast, but you do have adequate time there to get it all done, I think. And I think if people are really wanting to be a hardcore researcher, they want research to be a major part of their long-term career, I would encourage the K award track. I think it was good for me, and I think it's been good for most that did it. I think if you're kind of on the fence and you're happier with maybe doing clinical practice and being a contributor in clinical trials that are led at other institutions and so on, then it may not be appropriate. But if you really want to be the leader of like multi-center studies down the road, I think having that time to learn that skill set is very helpful. And it's just the best chance of getting funded in those first 5 years out as well.
Yeah, and to your point earlier, I think just finding an institution that's willing to invest in you as a investigator and willing to give you the time to write papers and grants, I think is really important. I think the reality is that there's so much pressure for RVUs and productivity and what have you.
Yeah.
I think it's going to become increasingly hard to find an institution like that that will give you like a day and a half to write and things like that.
2 days, man. 2 days.
2 days, yeah.
A day and a half. A day and a half is going to be really 1 day, and then it's going to just. And you got to go to the dentist. You got to do all that other stuff, and it suddenly disappears.
Right.
Again, it's all about the time up front. And you're right. You need to. They are hard to find, but they're out there. And the other thing is a lot of institutions are not keen on K awards because K awards, while they give you 75% protected time, they don't pay you at the level of a clinician. And so, granted, you won't make as much as you would if you were a full-time clinician, but the institution eats a little bit of money on those K awards too because it only pays you to the NIH salary cap. So it gives you some decent salary support, but you're not going to be happy with an NIH salary where you are. So they're going to have to it's still some investment, even with the K award. So I know some institutions that are not proponents of K awards at all. And that to me is a red flag. It kind of basically says you need to get out there and just do it on your own, which is a little bit too cutthroat.
Yeah. And I think, even for those who are really seriously interested in academia, in pancreatology, I think like even a pay cut is something that we need to be prepared to take for a few years in order to buy that time, like 2 days a week, like you say, because I think, I'm 5 months in as a faculty and just like getting busier and busier and just not finding the time. So, it's
a trade-off. And the other thing is you excited, you're you don't want to seem like you're lazy, and that's very hard for people that don't do research. And it's like, well, like I hate it when people say, "Oh, it's your day off," or it's like it's not even even protected time is probably not the best. It's committed time. I'm committed to these other missions. And you're always going to get people that are looking at it and sort of scoffing at it, and it's very hard. And if you're in a situation where you're constantly having to say like, no, I'm not available, I'm doing, this is my research time. If you're having to say that and defend that on a regular basis, that's a problem. You want to be at a place where the senior people are like, don't call Peter, don't call him, because he needs to be, this is his research time. And you need that for, a 1-year gig is not enough. It's really 2 to 3 years is what you need. Because even the Ks, it's more likely to take you a second cycle than you will get it on the first one. So those are all very important. And it's hard to do. It's definitely hard to do, but it's, for people that are willing to come up on a Super Bowl Sunday and talk like this, I think you guys are have a leg up on the competition. I think honestly, it's just there's not a lot of people really truly committed to it. So if you are, you've already sort of achieved the first big obstacle.
Okay, it's 2:49. We've covered all the questions. I'd like to just open it up for open session for a few minutes before we close. So anyone who wanted to ask any burning questions to Dr. Cote, the very busy guy, so you won't get another chance. So just fire away.
Dr. Cote, so thank you so much for coming in for this meeting. And so we really want to thank you for being such a great advocate for trainees. And I've seen you participating in all these meetings and being so energetic. So quick question, for someone transitioning from a trainee to a junior faculty, what advice do you have for someone looking for jobs and trying to establish a career in academic medicine?
You get a job at a place that has a critical mass of practicing docs in the area that you're interested in, so you're not just going in and filling a void, because then you're even if they say you have committed time for research, you're not going to get it, because if you're bringing that unique skill set, you're going to get pummeled with clinical work. So needs to be at an institution that's deep enough that they can bring you on, and provide you enough business that you can develop your skills, but not so much so that you're inundated. I think, for the pancreas stuff, I think it's a minimum of 2 to 3 other people at an institution. You want to know obviously what their volumes are. So if they are fighting for cases within each other, and then you're going to be the 4th person, that's an issue. You want to go to a place where they are busy enough that they can bring someone else in, but not so busy that you're going to be overwhelmed. You want to be getting 200 to 300, ERCPs in the EUSs if you're doing those types of cases. And if you're not, if the medical pancreatology angle is, I think, a little bit trickier, because I think since there's not as much technical, the technical aspects of that career are different. I think you can be the only medical pancreatologist at an institution, as long as your pancreatic endotherapy group buys into the importance of that individual. Because I think it's easier to get distance mentorship and expertise in medical pancreatology than it is in pancreatic biliary endoscopy, if that makes sense. So that'd be the only caveat I would place on that issue of infrastructure. And like I said, it really is a division chief who sets the tone, and a department chair sets the tone and saying, look, we're going to invest in this individual, and this is how it's going to go. They need to show you what your mentorship is going to look like, and it needs to be very clear in writing how they're committing to you as far as time and resources, and then then it's on your shoulders to be successful in that first 2 to 3 year period. Start to make some progress. Does that answer your question?
Yeah. Yes, exactly. Thank you.
Dr. Cote, I was hoping also to ask a question regarding that in terms of, we start to see some medical pancreatology fellowships pop up. And, I'm doing an advanced year, and it's like, I don't really want to do another full year of training, but I definitely want to get some training in medical pancreatology. I was wondering how you would balance that, or are you a big proponent of doing the full year of medical pancreatology?
No, I think if you're doing interventional, I think that would be, I agree with you. It's just too much. And you got to get out and start making some money, and living the rest of your life. You've already invested so much time in your education. So I don't think it's fair. The only scenario in which I would say that might be acceptable is if you are, let's say, working at a place like Mayo or Pittsburgh that has both of those opportunities. Then you could envision a situation where you're put on faculty, but that as part of your first year or two on faculty, you're given a chance to work still under someone a day a week or something like that. But short of those few places with medical pancreatology fellowships, I'd say the best way to get that mentorship is perhaps through something like what the IBD societies have done, where you get the 1 month sort of immersive experience. And I think, if you can go to someone's clinic 3 days a week for 4 weeks and see how they practice medical pancreatology, I think that gets you started. It admittedly is not going to be as robust as the full year, but it helps you at least start to think about the issues that are specific to that, and then hopefully links you with someone that you can then work with and say, what are you doing as far as when do you get bone densities on people with chronic pancreatitis, just for example. Something that an ERCP provider would basically never think of. I like that. So I think that's how you should do it. I think if you're the other way, if you're going down the path of a medical pancreatology fellowship, then it's important to have collaboration with the interventional group, because if you work completely in isolation, you're going to have a hard time studying, a lot of the issues that are relevant to us in this area. So I think it's, for the interventional person, you should not put it on yourself to do a whole other year, but perhaps, a 1 month immersion in your first year on faculty. Again, this is like a division chief would invest in this, right? So if you're coming out of your 4th year and you say, I really want to be a true pancreatic physician, and I want to do pancreatic endotherapy work, pancreatic endoscopy, but I want to have a broader clinic experience with my patients, follow them more longitudinally and so on, and offer these other things. Would you allow me to go somewhere for a month during my first year on faculty to get that? And that would be something they would pay you for. That's the type of thing you can talk through with your division chief as you're getting your first job.
Great, thank you.
I have one question as well. Dr. Cote, thanks for joining us.
Yeah.
And great information about the grant and career development awards. I will build up on David's question and maybe make it more complicated. So if you are trained in advanced endoscopy, but you have interest in pancreatic disease, and you also have master's and strong interest in clinical and translational research, and planning to apply for career development award, so you don't want to lose your advanced endoscopy skill set you learned during the training, but you also want to follow up these patients somewhat longitudinally and have that clinical experience, and also at the same time want to be enrolled actively in translational research and write the grant. So what do you think in your head that you still keep your endoscopic skills in average? What do you think that number will be? Like 10 minutes ago you mentioned 200, but I think if you are doing all of these things combined, it will be challenging in an institution to reach that number. Or how would you recommend balancing those?
No, I think that's important. You should be able to do that if what it means is sacrificing, right? It means you're not going to do very little colonoscopy. You're going to do very little upper endoscopy, luminal work. You're not going to be an EMR person. You're not going to learn POEM. You're not going to do bariatric endotherapy. Your time is going to be Panc Billy. It's going to be Panc Billy EUS, and ERCP. And if your endo blocks need to be heavily weighted accordingly. And again, that comes with being at an institution that has the catchment, the referral base. that can support that for you. So when you come in and do hopefully 4 to 6 ERCP EUS on the days that you're scoping, I think the math will work out. If you're doing that 2 days a week, every week, you're doing 12 procedures to of course, with EUS, you'll be able to do more. But if you're doing 12 procedures per week for 50 weeks, that's 600 pancreatic cases, right? And so obviously it's not going to be a perfect. You're going to have some obligation to these other procedures, particularly colons and EGDs and stuff like that are so common. But you can do it. You can get that exposure, again, as long as you proactively limit your practice. If you try to be an all-encompassing, classic interventional endoscopist that tries to do a little bit of everything, you'll fail. You're not going to get the numbers. So you have to say, like, I'm not going to do these things. I'm just not going to learn POEM, not going to learn even big EMR. If you're given in your training the opportunity to do like a really cool rectal polyp, big 4 or 5 centimeter laterally spreading lesion, or you can do 2 diagnostic EUSs maybe with an FNA, do the EUSs with the FNA. You have if there's 2 rooms running. So it's challenging because a lot of things, this is why I have mixed feelings about how the 4th years are structured right now, because I think it's deteriorated in a lot of ways. It's too diverse, and we need to separate into luminal people and pancreatic people within the endoscopy world. But if you really want to go down with that pathway that you just described, you can do it as long as your clinical practice is catered accordingly. And it gets easier as you do it longer, because then your patient population will be inherently pancreatic disease. And as you push the other diseases to other individuals in your group.
Okay, we have time for one more question before we close. Anyone? Okay, Dr. Cote, so any last piece of advice you'd give to the trainees that dedicated enough to attend the session on a Super Bowl Sunday?
Yeah. Well, just, I think it's all about writing, at this stage, write. And you have to have an iron constitution, because you're going to get a lot of rejections. You're going to get a lot of negative kind of stuff as you do this, and you just have to push through that. But it's all about volume. It's all about volume. Go for the base hits. I think early in your career, don't try to do the 7-center, multi-center trial right out of the gate, because these things are very infrequent in endoscopy at all. Build up the portfolio so that a few years from now, you've got the experience. You've learned, a lot of times the hard way about what works and what doesn't work. You've learned about who are good collaborators and not. And then you'll be in a position to do some of these bigger things later. And just obviously you want to be with senior people that have a track record. So, and I would look at the best way to do that is to look at who they've trained, where are they now, and what about publications? Like, if you're constantly being found as the second author behind someone who's an associate professor, that's not a good mentorship model, right? They need to be giving you the primary authorship on these papers. So, I think those are the key pieces that you need.
Okay. Well, that was extremely helpful.
Work together with each other, which is what this is, which is why this is so great, is to work together. I mean, you guys are all from different institutions, and I'm sure do things differently. And so it provides a great natural environment for research, right? On how people treat this or that. If you take all pancreatic stones, how are they treated at your 4 institutions right there, all comers. I'm sure you'll see major practice differences.
Right.
And again, try to bring in some of these very important patient-centered kind of things when it comes to the pancreas that endoscopists are terrible at studying. Don't do big-time research with outcomes that are focused on the technical aspects of the intervention. Focus on the things that really matter to patients.
Well, that was extremely helpful and really encouraging, to be honest. Thank you very much for your time. And I just, everybody happy Super Bowl Sunday.
All right, guys.